Hi, my friends. I'm Florence, and I work in Changhua Christian Hospital as infection specialist since 2015. It's my pleasure to share this lecture with you. Please feel easy to give any advice. Today, I would like to have the topic about the antibiotic do and don'ts. In 1967, William Stewart has said that chronic disease such as cancer, cardiovascular disease, and diabetes would soon take over as the leading causes of the mortality. This is the time to close the book on infection disease, as we basically wake up infection in the United States. However, this is not applicable at current, as much of the infectious diseases are emergent. Why we need antibiotics? Because in severely ill patients can benefit from use of antibiotics. We should prescribe the antibiotic while infection is suspected in clinical. However, we should use the antibiotic carefully, avoiding abuse the antibiotics. The most common conditions abuse the antibiotic that the symptoms are mild, which caused by the other reasons, such as the virus infections. If we don't restrict the antibiotic using, by the time passed, the resistance strength will increase. This is a war between humans and microbes. We must use our weapon, antibiotics, with caution to avoid out of the ammunition early. There are some myths about the antibiotics. In clinical, there always has some myths about antibiotics. The newer generation of the antibiotics always stronger than the older ones, such as the fourth generation cephalosporin is always better than that one, and the second generation always better than the oldest one. And if the antibiotics have the higher price, it's always have better effect than the cheaper ones. The other myth is about that we use the broad-spectrum antibiotic is better to cover the bacteria that I haven't known, even though the pathogen has been isolated. The antibiotic restricted in the antibiotic stewardship always better than the one non-restricted. This is all the myths about the antibiotics. In clinical, we always require for stronger antibiotics as patient in clinical illness or unstable of the vital sign. But please wait. What is the stronger antibiotic? Do you mean the potency, or efficacy, or more spectrum, or better penetration, or what else? In clinical, antibiotic that could better resistance strength does not necessarily mean that better antibiotic for every patient. For example, while we talk about the Staphylococcus aureus, in the journal study, it points out that the oxacillin have better treatment effect than the vancomycin in the oxacillin-sensitive strains. As we know that prolonged antibiotic use will cause many adverse effects. While the third or fourth cephalosporin use, we will select enterobacteriaceae that carry genes ESBL or MC. Whereas the fluoroquinolone usage amount increased, we will select enterobacteriaceae that resistant to the quinolone or the Acinetobacter, Pseudomonas aeruginosa. If the bugs increase, nothing to blame, increasing using of the carbapenem usage. Coming behind is resistant to the carbapenem. In addition, this will collaterally damage to our inner microbiome with increasing vancomycin-resistant enterococci or MRSA. This slide also points out that while the antibiotics using is increased, the resistance strength is increasing. This paper points out that while increasing of the usage of the antibiotics, increasing the resistant pathogens. In Taiwan paper point out that the rising in the extended spectrum cephalosporin proportionally rising of the independent resistant pathogens, whereas increasing of the carbapenem usage, increasing pan-drug resistant Acinetobacter baumannii. Not only in Taiwan, we can also observe this phenomenon in nationwide. After fluoroquinolone use, elevation of the resistant amount of E. coli, Proteus mirabilis, Klebsiella pneumonia. In European countries, rising amount of the penicillin non-susceptible Streptococcus pneumonia, followed by the antibiotic DDT increasing. After plenty usage of the third generation of the cephalosporin, we will select VRE, ESBL of the KP, beta-lactam resistant Acinetobacter species. After plenty usage of the quinolone, MRSA quinolone-resistant GNP, including Pseudomonas aeruginosa, will increase. What is the adequate antibiotics usage? Before answering this question, we need to discuss about the generation principle of the antibiotic use. Commonly, we use antibiotic in three circumstances. We use it prophylactically, empirically, therapeutically. In some circumstances, we use antibiotic to prevent infection while patient is not infected, such as before the surgery, we give antibiotic prophylaxis to avoid the surgical site infection. We also use the antibiotic prophylaxis in the immunocompromised patient, as this patient has weak defense mechanisms. Before visiting high malaria prevalence countries, we give malaria chemoprophylaxis to avoid getting infection. Before any dental procedure and other invasive procedure, we use antimicrobial prophylaxis to avoid getting bacterial endocarditis. After the solid organ transplantation, always use anti-infective chemoprophylaxis. For those contact with the patient with meningococcal infection, we give prophylaxis antibiotic to avoid getting serious infections. In those recurrence of the psoriasis frequently, we will give prophylactic antibiotic to decrease the frequency of attack of the psoriasis. This is the conditions are allowed to use the antibiotic even they are not infected, as it could decrease the disastrous disease. In patients with suspect or probable bacterial infection, such as they have the sepsis sign, leukopenia with fever, suspect infective endocarditis, or bacterial meningitis, or necrotizing fasciitis, we use the antibiotic empirically, even we haven't known the pathogen. Before using any antibiotic, we need to take the history carefully and do the physical examination thoroughly the patient to ensure patient has the infection. This is the cornerstone to approach the infection disease. The most common etiology of fever is infectious disease, but there are some diseases also cause fever too, such as the autoimmune disease, malignancy, or drug allergy. To avoid abuse antibiotics, before prescribing antibiotic, we need to deliberately answer 10 questions. On the clinical, does the patient need antibiotic? Before antibiotic, do we submit the appropriate culture? What is the most common pathogen or probable pathogen? What is the best choice of the antibiotics? Do we need to combine the antibiotic? Does the patient need debridement or surgery? What is the most appropriate antibiotic route? How much of the antibiotic doses is needed? After the culture, do we need to adjust the antibiotic? What is the duration of the antibiotic courses? That is definitely need antibiotic in severe disease such as bacterial meningitis, infective endocarditis, leukopenia with fever. In less severe disease, but the patient has definite bacterial infection such as the bacterial pneumonia, psoriasis, we also suggest antibiotic using. In patients with fever lasts more than 1 week that remain in finding the etiology of the fever, the antibiotic usage is controversial. The most common overused antibiotic is the common cold. If the patient is in the clinical status, we suggest to use the antibiotic as soon as possible, especially if patient has obvious infection focus. The patient is vulnerable. The patient is sepsis, leukopenia with the fever, probable infective endocarditis, bacterial meningitis, necrotizing fasciitis, or myositis. This patient will suggest to use the antibiotic as soon as possible. If the symptoms sustain for 1 week without deteriorating, it might not necessary to prescribe the antibiotic immediately. As the bacterial infection might less likely, we need to have the comprehensive data collection, submit every possible specimen. Before using any antibiotic, we need to submit every possible specimen. If we consider bacteremia, we should collect at least 2 sets of blood culture. If infected endocarditis is suspect, we need to collect 3 sets blood culture. If we consider UTI, please submit the urine culture. If the osteomyelitis is suspect by clinical, we can make the image study or we need to have the indirect evidence of the blood culture. If we don't have any pathogens, I suggest to have the bone marrow aspiration. We need to collect every culture before antibiotic, as the culture might yield negative results even under 1 dose antibiotic. We collect aerobes culture from the urine, sputum, wound, body fluid. We need to submit every specimen if possible. If the clinical is stable, we need to collect at least 3 sets from the different sites. It takes 1 to 2 hours spent. In the subacute infective endocarditis, it could spend 24 hours. If the clinical condition is critical, we collect 3 sets per culture within 20 to 30 minute time spent. But we not necessarily submit sputum culture every day or 3 sets. In addition, we submit sputum culture only while patients have diagnosed as pneumonia. Submit concurrently with sputum gram stain. There is an exception. While the pulmonary TB is suspect, we need to submit 3 sets sputum in every day is acceptable. Before antibiotic use, we also could submit gram stain, HE stain, Indian ink, or other methods that could help us increase the probability of the diagnosis so that we can use the antibiotic soonly. There are some rapid detection methods such as the pneumococcal urine antigen, Legionella urine antigen, influenza antigen that is rapid to have the result. It could help us for rapid diagnosis, although these tests also have the limitations. Before antibiotic using, we could screen the infection focus, which is the most probable site of the infection. What is the probable pathogen in this site? Is that community acquired or healthcare associated? Patient has used antibiotic before? All these questions will help us to use the antibiotic properly. In addition, how old of the patient? If she pregnant, how is the liver and renal function? Is patient have any underlying disease such as the G6PD, or do patient have the specific risk factors such as the prosthetic valve with fever? These questions make us use antibiotic cautions. Before antibiotic using, collect the blood culture as soon as possible. If possible, please do not script antibiotic before blood culture. Does the patient have the hematology disease or the connective tissue disease? Is he in the neutropenic status? If so, we suggest the bactericidal microbiome. There are some diseases related specific to the specific pathogens. If the patient have the diabetic mellitus, most of the liver abscess caused by the KP in the Taiwan. There are some different epidemiology in the other countries. If patient is alcoholism, he also prone to get the KP infection. Patient who use the steroid prone to have the nocardia, TB, salmonella infection. Patient with the liver cirrhosis prone to be infected by the Vibrio bonificus, Aeromonas, hydrophilia, necrotizing fasciitis. Patient who has splenectomy easily got to the Haemophilus influenza, Streptococcus pneumonia, Klebsiella pneumonia infection. If patient is in the neutropenia status, we are afraid of the Pseudomonas aeruginosa infection, which will have the high mortality. If patient with hypogammaglobulinemia, easily to get the encapsulated bacterial infection. In the head and neck infection, there are some pathogens prone to involve these organs. If meningitis is diagnosed, Streptococcus pneumonia, Neisseria meningitis, or the Haemophilus influenza, sometimes Listeria monocytogenes should be considered. So we always use the third-line cephalosporin such as the rocephin plus the ampicillin if we think of the Listeria monocytogene. If sinusitis or the thick neck infection is suspect, we consider the viridin Streptococcus pneumonia, Haemophilus influenza. We can use the ampicillin sulbactam to cover these pathogens and the anaerobic pathogens. In the community-acquired pneumonia, mostly infected by the Streptococcus pneumonia and Haemophilus influenza, Mollasella catarrhalis, and the Staphylococcus aureus, and also the atypical infection, atypical pneumonia. Therefore, we can use the ampicillin sulbactam, cefirozin, or oxacillin add-on macrolide. For the nosocomial pneumonia, we always use the anti-Pseudomonas antibiotic to cover the Pseudomonas aeruginosa, GMB, and the Staphylococcus infection. In peritonitis or the intra-abdominal infection, we always need to cover the GMB and the anaerobic pathogens. We could use the cefmetrazole, bromosafe, or third-line cephalosporin plus the metronidazole. Also, we can sometimes use ertapenem or imipenem. In the acute pyelonephritis or the UTI, we need always to cover the GMB, Enterococcus candida. So we always empirically use the cephalosporin, ampicillin, or the fluconazole. The most common pathogen in the urinary tract infection are E. coli, nearly 90%, whereas the Staphylococcus subproticus account for the 5% in the young women. The Proteus mirabilis relate to the urethral stone or urine catheter. If the Staphylococcus aureus is isolated in the urine specimen, we need to seek the source of the septic emboli. In the psoriasis and soft tissue infections, Staphylococcus aureus and the Streptococcus or Clostridium are common pathogens, so we always use the oxacillin or the penicillin G. In the septic arthritis or osteomyelitis, most common natural pathogen is Staphylococcus aureus. In patient has the operation before, GMB could be considered. So we always empirically use the oxacillin. We need to decide the antibiotic depend on the pathogen. Do we need to combine the antibiotic? It depends on the epidemiology data on the local. We also need to consider what kind of the infection, what site of the infections, and the proportional of the local drug resistance strength, what is the distribution of the drug susceptibility test. If the resistance rate is high, of course, combination therapy is suggested. Sometimes we use the combination antibiotics in order to have stronger bactericidal effect, no matter synergy of additional, such as the enterococci. We use penicillin and aminoglycosides to have the synergic effect. For the Pseudomonas aeruginosa and the Enterobacteriosis, we use the extended-spectrum penicillin plus the aminoglycoside. Sometimes for some disease, we want to avoid developing the resistant bacteria, such as pulmonary TB. We always use the combination therapy. In patients infected successively or at the same time with more than one pathogen, we always use the combination therapy, such as the patient got the intra-abdominal infection or pelvic infection, it is prone to have the combination therapy. If the patient is in neutropenic status, we always use the combination to have broad-spectrum coverage. Of course, combination therapy will have some side effect. It may increase side effect of the drug or increase the chance of the allergy. It also increases the chance of colonization of the resistant bacteria. It is the higher cost of the combination therapy. So sometimes it may also cause antagonism instead. After the combinations, physicians sometimes will have the false sensation of a security. Therefore, they're neglecting other necessary preventive or therapeutic measures. Except for the antibiotic, we need to think whether this patient needs the debridement or the surgery, because someone said that the surgeon's scalp is the best antibiotic, and the radiologist's drainage tube is also a good antibiotic. Both of them could relieve the bacterial load rapidly. For example, the huge lobulated abscess, we suggest to drain the abscess. Such as the empyema, we suggest to have the chest tube drainage. If the patient has the necrotic tissue, we need to debride. If the implant is get infection, we suggest to remove the implant if possible. Of course, if the hollow organ perforation, we suggest to repair the perforation. Before prescribing the antibiotic, we need to know what is the pathway of the drug metabolism, what is the appropriate antibiotic route. Can it reach the infected site effectively? Will it interact with the other drug or affected by another drug? What are the toxicity and the side effect of the drug? There are some antibiotics are metabolized through the liver, such as oxacillin, clindamycin, and there are some metabolized by the kidney. Most of the beta-lactam aminoglycoside, this is metabolized by the kidney. After consideration, we need to decide what antibiotic to prescribe. Through which route is through the intravenous or intramuscular or enteral. What is the medication doses and the frequency? How long is the therapy duration? We need to combine or not. This is the factor we need to consideration. Some organs have poor penetration of the drug, so we must select antibiotics that can effectively penetrate these organs, such as the CNS and the endophthalmitis, prostatitis, meningitis, endocarditis. This side of the infection, we need the higher doses and we need to choose the antibiotic that could penetrate better to this side. After the culture, we need to give the antibiotic as soon as possible. Intravenous infusion is better for patients in shock or poor intestinal function. We always use the bactericidal drug whenever is possible. We need to select the antibiotics that could cover more than 80% of the possible pathogens. Generally, we have the 4 principles for the medications. We need the high efficacy, narrow spectrum, high safety, and also low cost. After the culture, do we need to adjust the antibiotics? It always have the many circumstances will happen in the clinical. If our culture result is susceptible to our antibiotic and the clinical is stable, we could switch the antibiotic to the cheaper one or the narrow spectrum or the lesser side effect medication. However, if the culture is susceptible but the clinical is worsened, we need to make sure whether this is the disease natural cause or we have made the wrong diagnosis. If our isolated pathogen is resistant to our antibiotics, but the clinical is improving, what does that mean? Is the disease healed spontaneously or the isolated pathogen are incorrect ones? We need to change medication or not? What do you think? No matter which is our answer, the patient is improving. That is the result we want. If our isolated pathogen resistant to the antibiotic, but the clinical it also become worsened, definitely we want to change the antibiotic to the effective one. If there is no pathogen have been isolated, but the clinical is improving, no matter it's improving spontaneously or what else of the reason, this is the result we want. We just keep the therapy. If the clinical is deteriorating, we need to revise our diagnosis and what else clues we had missed. This is depend on the clinical and the principle I had mentioned before. After the antibiotic use, we need to use the how long of the antibiotic. Usually it depends on the risk of the disease relapse, also the infection site, the bacterial species, speed of the clinical response, if patient has the abscess or not. For example, for the pneumonia, the duration is always depend on the clinical response. However, when the bacterial meningitis is diagnosed, it usually takes 1 to 3 weeks. And the endocarditis is usually takes 4 to 6 weeks. For the osteomyelitis, we suggest more than 6-week therapy. This is the common duration of the disease. Before ending of the speak, I would like to share a case. This is the 96-year-old man with the type 2 diabetes mellitus, hypertension, hyperlipidemia, stroke with the bedridden. He was admitted due to the pressure sore related muscle bacteremia. Also, he got the pneumonia. Antibiotic vancomycin and the tazocin were used. After a week therapy, we discontinued antibiotic vancomycin. However, patient had recurred of the fever after 2 days of the antibiotic vancomycin discontinued. What will you do? After examination and history taking, he was shocked. We kept the tazocin and enhanced the chest care. The chest X-ray follow-up compatible with the pneumonia. After the tazocin use, he became stable. For every new onset of the fever, we need to survey every possibility. not only think that there is not enough antibiotic use or because of the discontinuation of the antibiotic. Another case is 41-year-old man with liver cirrhosis. He was admitted because of the left ankle septic arthritis complicated with the Klebsiella pneumonia bacteremia. It seeding to the bilateral pretibial area with soft tissue infection. There are some abscess, so we aspirate the abscess intermittently. His blood culture yield the Klebsiella pneumonia. It is susceptible to the cephalosporin, but the fever persists. Then what we will do? We change the antibiotic to the cephalosporin. The fever is subside. Do you think that this fever scent is because of the rocephin? A day before the fever scent, we insert a pigtail to his lung due to much poor effusion, which the poor effusion show the actual date. His glucose level is less than 10 mg per deciliter. The LDH is more than 27,000, and also the WBC is high, it's 85,000 with the neutrophil predominant. In these cases, we need to drain the abscess if possible. We need to prescribe the antibiotic carefully, as antibiotic also brings some side effects, such as the Clostridium difficile infection, gastroenteritis, diarrhea, increase the antibiotic-resistant organisms. In some people also have the allergic to the antibiotic. For antibiotics, it is not an antipyretic agent. Not every fever needs antibiotics, as even when under antibiotics, patient might remain have fever. Also, antibiotic not an anti-inflammation agent, as even under antibiotic, the organ remain in inflammation. The most important, the antibiotic not anxiolytic for the clinicians, as even under antibiotic, you may still insomnia. We need to survey every possible for fever causes or infection focus. The antibiotic, not the broad spectrum you use, the better. Not the more you use, the better. Not the larger doses you use, the better. Not the longer you use, the better. We need to have the optimal selection. Doses and the duration of the antibiotic is important. That is my speech. Thank you for your attention.